Hello, welcome to our presentation about documentation. We're going to talk about the importance of documentation and what it means, why we do it, and why it is so important to what we do. It's one of the most important things that we do as EMS providers is to provide proper and correct documentation. I don't know if you noticed, but on the previous slide, there were several mistakes. There was spelling errors. There was no apostrophe. The wrong word was used, although it is a correctly spelled word, it was the wrong word. These small errors can bring your credibility into question. If you're ever called to court, if you ever have to defend what you did, what you didn't do, or anything, these little small things can be held and used against you. A good lawyer will take these things and say, well, you didn't take time to proofread, to capitalize properly, use correct grammar, punctuate, use commas, use apostrophes, whatever it is, they can use those to discredit you and say that your patient care is just as sloppy as your documentation. They could even argue that you just pencil whipped it, just because you were too lazy to go back and document correctly is again a reflection of your laziness, is also a reflection of your patient care. So why do we document? We document for medical reasons. Again, this is a medical chart. It is a part of the patient's permanent medical record. It is something that physicians use in the ER, on the floor, surgeons, post-care, specialists, everybody in the patient's care continuum will use your documentation a lot of times to see trends, to see what was going on when an event occurred, to go back on trauma patients and look at mechanism of injuries, so many different things that they will actually go back and look at. And a lot of times this doesn't occur till days later, when a physician is trying to put a whole picture together. There's not a lot of time in the ER for critical patients for physicians to go back and read your documentation. But once they get onto the floor, once they get in ICU, that's when a lot of times they will request EMS documentation and go through that and try to use what you have provided them to better care for that patient, to have a better outcome. So the more detail, the more that you put into proper documentation, the better that they can serve and provide for that patient what they need. Administrative, obviously, it's proof that you did your job. It helps for bill collection, we'll talk about later. It's something that will be used for quality control. It's something that we can use to help to justify things that we ask for. We need equipment, we need certain medications, we need whatever it is. So administratively, it is important as well. For research, research is new in EMS, but it is huge. There's been lots of changes recently, and it's all because of research. Spinal immobilization is one example. How did it come about? Why do we immobilize everybody that fell down? Everybody that was in a car wreck. Why do people stay on backboards for so long? They've been able to actually use research based on our documentation and studies to show and to prove that spinal immobilization is, putting everybody on backboards, rigid backboards that are flat, is not good for them. It causes a lot of problems for the patient. ACLS, another thing. People complain all the time about, well, why is it changing? Well, when ACLS started out, it was based on theory. And over the years, they've been able to do trials and test and look at documentation and look at data to say what works and what doesn't work. When I first started, we did compressions was five compressions, one ventilation. You know, it moved and morphed to what it is today. And that's all based on research. And we have seen that because of that, we have better patient outcomes in a lot of ways. We have Lucas device. We have a lot better understanding of ventilation and even how the compressions really work with perfusion of coronary arteries and brain and kidneys and things. So research really drives where EMS is headed, and our documentation is a part of that research, whether you know it or not. You may not be enrolled in a particular study per se, but they still do what's called retroactive studies, and they look at data that we provide, and based on that, we shape and help to shape the future of EMS. And not only that, it also helps to direct funds, which is not in here at this moment, but you know, based on trauma data, accident data, different things like that, you can help direct and funnel funds into communities, into services and providers where there is a greater need. Another huge area which we don't typically deal a lot with is the legal side of things. Administration deals with this a lot more than we do, as far as requests from lawyers, requests from patients, requests from insurance companies, and things like that, documentation about a particular call. You know, we all heard the commercials, the one call, that's all, you know, call me and I'll represent you, get you lots of money, things. And they really depend on our documentation in order to provide what they need to go after people to get money. So, and that's one aspect of it. You know, the request for PCRs, for refusals, for MVCs, for work accidents is really high. And if we don't document properly, then we are not doing justice to the patient, nor are we doing justice to the entity that may or may not be responsible for an injury. It's not our job to make determinations, it's our job to document. So if you go to a store for a slip and fall and there's water on the floor, that should be in your documentation. If the floor was dry, that should be in your documentation. We are to paint a picture, which we'll talk about shortly, to whomever reads our documentation so that a decision can be made. On the flip side, legally, it is also what will either protect or hang us. As I mentioned earlier, a good lawyer can use our documentation against us. But if we document properly, you know, we could have a good lawyer that can use our documentation to defend us. I know personally, I had to go to court over documentation, but it was not against me. It was against my patient, actually. The police were on a scene. It was a car accident, a single car accident, and they did not document. And so the lawyers leaned on my documentation to try to prevent insurance from, is what it was, a workers' comp thing. And the argument was that the patient was drunk, but the police chose not to document because they did not want to go through the paperwork and do their documentation. So they just wrote it off as a, you know, an accident, and I had got a refusal on that patient. But the lawyer, their questioning to me was not so much even about the patient, but it was about the scene. And I did put some things in there about the scene, but not enough, in my opinion. I don't know what the final outcome was, but you know, I remembered bits and pieces because it was several years old, but it was not all in my documentation. So therefore I couldn't, you know, really bring that up. They were asking me some things, but I just kept referring to my documentation. And So that's, again, that taught me a lesson, is the importance of documenting what you see. You can't rely on somebody else to do their job and to document, but you can certainly control yourself and the way and what you document. So medically, again, just to kind of recap, you have a record of an injury or illness for a patient. Again, it's a permanent medical record. It's something that is always there, that can be drawn upon. And as we know, some injuries have long-lasting effects. Some injuries can have effects years down the road, and all these things. And so it is important to document so that if they're needed, then they are correct. If they're not needed, great. And we always hope that patients have full recoveries and don't have to depend on things that we did or did not document. It's a record of the care that you gave to that patient, any treatments, any assessments that you did, anything that you provided for that patient, including transport or getting a refusal or bandaging and education, or whatever it is a record of what you did. It is huge for documenting trends, and this tends to be a little more important whenever we come across critical patients, whether it be trauma or medical, because we look for trends. And again, that's something that the ICU doctors and surgeons and even sometimes in the ER, although that's not a huge thing for them, but they may ask you what trends are, especially for vital signs or GCS, or if you have a diabetic, that's hard to control, what are the trends that this patient has shown you over the time that you dealt with them. So it's important to document correctly the times and the values associated with those trends. It is a medical timeline. So again, it is, from start to end, a progression of someone got better, someone got worse, someone stayed the same. So whatever it is, it's going to account for your time that you arrived at the patient, and even prior to, based on your history and your documentation of the scene, up until you hand that patient care off, to give someone a good representation of a timeline. So we need to be sure that we manage our timeline well and do not allow it to get away from us. That is something that can be challenging at times. So administratively, again, we're looking to record what you do. You're proving that you're valuable, that your job has a reason to exist. You want to get paid, you want to have a job, then we have to show that that we are needed. It's a demonstration of your job performance. It can help, for yearly evaluations. It can help to keep you out of trouble, or if somebody complains against you, or whatever it is. It demonstrates your performance of your job, how well you did your job. On the flip side, it can demonstrate how poorly you did your job. And that is not what we want to convey, so we want to make sure that we do a good job. We justify our charges that we bill the patients. Currently, EMS is not allowed to charge per item that is done. It is kind of a flat rate thing that CMS controls, but it is currently in the works to have that changed, and we will be able to itemize the things that we do. And there again, if you have a charge sheet and that you charge that for IVs, for medications, for things, but you don't have documentation to back up that charge, then you cannot charge them. I'm not going to go too deep, but signatures are huge here. If you don't get signatures from the patient, then you can't charge them. If the patient is incapable of signing, you must document the reason why that patient is incapable of signing and get a proxy to sign for them, whether it's family, whether it's the receiving nurse, or whatever. So in order to bill, we must have signatures. In order to bill, we must have supporting evidence of why we charged what we charged. And based on that, you get paid. You know, we earn salaries through the county, but part of the reimbursement, and that helps us to justify our job and justify, you know, we're asking for raises and for extra things. If the county is able to collect on things that we do for people, then it offsets the budget and it can help to support our argument when it comes to raises and to help support our argument for our job performance and the need for even more people. So it's defense from CMS. CMS is this acronym that's used. Basically, it means Medicare and Medicaid. It's the federal government, and they do audits. They don't typically just randomly go do audits, but they do have the ability if they choose so. Typically, how audits work through them is that there's a complaint, there's an issue that arises, and so they will go and do an audit. And they don't look at every single PCR that we did in a year. They take a random sampling of PCRs and they will look through those, and they're very critical in how they look through them. And any error they identify through this sample list, for example, that may take 10% of the calls, and they find an error rate of 10% of those 10%, then they use a mathematical formula and they multiply it out and say, so if this is 10%, 100,000 calls, you know, they reviewed 1,000 calls and they have a 10% error, then they multiply that out and say, based on your error rate for our sample size, we're going to apply that to your entire call volume, and your penalty and your fine will be based off of that. And it's huge. It can cost you millions of dollars. It can cost the county millions of dollars if they chose their sample and it happened to have the biggest error rate. Whereas the totality and the reality may be that the error rate is nowhere near 10%. The error rate in our top total call volumes may only be 1 to 2%. But based on the sample that they choose is how they're going to determine the overall error rate. So we have to be able to go back to anybody's documentation and prove and show that, you know, that our error rate is low. And that can be huge when it comes down to job performance, justifying bill, and getting paid, you know, for everything. If we don't do well, then we end up giving free EMS because we will not get paid for our transports. So on the research side, to go a little further in, you know, we have state and national databases that we have to report to. You know, we have all these little boxes we have to check and click on when we're doing our reports. That's data, male, female, age ranges, all these different things are databases that go to the state and the national database where they can do queries, trauma, vehicle accident, rollovers. If you know the section where it wants to know what was impacted, was there a death in the vehicle? It not only goes to the risk for trauma and the significance of trauma, but it goes to the national database so they could say, you know, Coweta County's MVC rate compared to the nation or compared to the state or compared to a certain section is X, you know, and of all of these accidents, X amount is front end crashes, X amount is side crashes, X amount is rollovers. And a lot of research can be done off of those retrospective data points. So the department has its own database, and and it's just part of the record. So the department can actually go in and run numbers, right? They can run numbers per truck, per station, per area, whatever the parameters are that they choose. They can put in that query and it will give data. But you have to remember, as we've always heard, garbage in, garbage out. If the data is not correct and accurate, then the data that is produced, the results, will not be accurate either. Professional research. Again, that's some of that retrospective studies where people will actually come in and look at data, cardiac arrest stuff, stroke. You might look at a particular drug and how it interacts and how it works for certain people, certain types of calls. Pharmaceutical research, again, drugs. There was a huge drug study in Atlanta several years ago. There, people look at does TXA something that is beneficial in the field, and it's pharmaceutical research. Atlanta was, what is the best drug to give to a seizure patient? And versus we give Valium, whatever it is. These pharmacies research that, and they will support research on those things. Procedure research, I mentioned the long backboard. Is it beneficial? Is it not? KEDs. What type of splint would be best suited for use in the field? Would it be cardboard splints? Would it be orthoglass? Could it be SAM splints? Could it be sticks and gauze? Who knows? But those type things can be done for procedures, for equipment, or whatever it is that we need to do. And we could do in-house research based on some of these parameters. Statistical research, I've already mentioned, is kind of a part of all that, where you go in and you look at statistics, whether it's race, ethnicity, sex, or gender. Any statistical information that you want, you can look at. You can look at private industry, accidents, illnesses. What is there more of a rate of an illness at Yamaha versus Walmart, or whatever it is that we want to look at. Those could be indicators that could be used depending on what you want to research. Legally, so it is the legal document of your patient encounter. It has to be maintained and kept as a part of the permanent record for that patient. And the department is obligated to keep this information for a certain amount of years. And if ever asked for it, then they have to be able to produce it. Could get in a lot of trouble for saying, oops, we lost it. It's evidence in court, as I've already mentioned. It can work for you, it can work against you. It may have nothing to do with you. It may work for your patient or against your patient. There again, we are to be non-biased. That's why we have the ways that we write, which I'll go over shortly. But provide factual information, to provide accurate information and accurate data. And again, it's part of that permanent record. There's different types of evidence that can be found. So you have state's evidence, you have the defense evidence, you have criminal evidence. So depending on, what's going on, your documentation can come into play with any of these, civil cases. So proper documentation is of the essence. So how should your documentation look? So your documentation should paint a picture. So we've got a few pictures here, and I don't know if everybody knows who this guy is, but he's a famous artist that you could watch on TV, and he would paint these pretty little pictures with his paintbrush and with his tools, and he would paint this magnificent picture over the course of 30 minutes on a little TV show, and you could watch it come to life. It was very impressive. Bob Ross is his name. You should look him up and see what he does and how he talks. He's very calming. So he is an artist. He paints pictures well. You can look at his picture and see the details in it. You know, you can see the water, the reflections, the shadows. You know, you can look and see that this is probably like a spring or a fall environment with the, you know, the mountains in the background that are snow covered, the clouds in the sky. You can really see a lot in his picture. And in this picture, you know, it's wow. Some people's documentation look like this. So, you know, it's just all over the place. It's random. There may be something there. There may not be something there. You know, so this is just one example of what some people paint. Here's another, you know, another thing. When we paint our picture is word art. So you may be writing words, but your words should form a picture in the mind of the reader. So it can be elegant, it can be rough, it can be descript, nondescript, it could be a work of art, or it could be like a kindergarten with a dull crayon. So we have to be careful, we have to be purposeful in how we write. So what do we document? We document lots of things. You know, where did we go? Why did we go there? What did you find when you got there? What did you do while you were there? Why did you do it? Were there any changes associated with what you did? Good or bad changes? Did you transport the patient? Were there any changes based on your treatments? How was the patient when you arrived at the hospital or when you left them after a refusal? All these questions need to be answered. Sometimes the answers are short, sometimes the answers are long, but we have to be able to answer these questions and even other questions through our documentation to provide the proof. We have to provide the answers, and we have to do it in a way that a non-medical person can understand. So how do we document? There's several different methods that I'm going to go over here. Our current SOP for CALIDA does say that you will use the SOAP or the chart method. So we'll go over those as well. It's not going to be an in-depth review, but a general review of these different types of methods. So the SOAP method is one that's a subjective, objective, assessment, and plan. Basically is how it's categorized, and you have each of these sections that you write. We do have to remember what they mean. Something that is subjective is somebody's opinion, more or less. It is a story behind what you went there for. It is people's words that they said. We can use quotation marks here. It's why you arrived, what, you know, the backstory, so to speak. So we need to make, sometimes this is a very large section, and sometimes it can be a short section. The objective part is objective. It is factual. It is assessment findings that you can say for a fact that, you know, somebody's skin was pale, somebody was diaphoretic, their breath sounds were clear, their breath sounds had wheezing, the cardiac monitor showed a second-degree block. Whatever it is, these are factual things associated with what you find. Your assessment in this particular method is kind of your working diagnosis, more or less. What exactly is going on with this patient? Because of my subjective and my objective assessments, my overall assessment of a patient may be that this patient is in congestive heart failure. This patient has a a broken ankle. This patient is in anaphylaxis or in sepsis or whatever, that is my assessment. And then the plan is obviously your plan of how you're going to deal with this patient. So it's your treatments, transports, any changes, any of those type items. There's the SOT method, which is kind of the same thing as SOAP, except for you take out the A. So you have your subjective, objective, and treatment. Goes along the same lines. With this method, your objective part really answers the assessment in the above method. So it's kind of all incorporated. Your chart method is more extensive and broad. So you have to make sure that you hit all those points and highlights. Again, some areas will be shorter than others, some areas will be longer than others. A narrative is more of a story. If you think of how you tell somebody about a call, hey, I went on this call the other day, and you kind of start from the beginning and go to the end, that is a narrative. You have the chronological, which is what it is. It's a timeline that you paint, that you write down from beginning to end. And so it kind of incorporates this in SOAP or chart or SOT, whatever, all those elements in a timeline rather than broken out into sections. There is the hybrid method where you can kind of combine a couple of these different methods to come up with a unique personalized method. I personally do that. I have a hybrid method that I use. It's kind of a blend between the SOAP and the narrative. And sometimes, depending on the call, it might be a little chronological, but it's this is a method that you develop over time, where you work with these different methods that works best for you. Then there's the auto narrative, which a lot of PCRs do offer. I am personally not a fan of auto narrative. If you are allowed to, if you choose to use auto narratives, then you must go back and edit that auto narrative, because it does not paint the whole picture. It does not tell you anything subjective wise. It only tells you objective points that are pulled from data that already exists in your PCR. So you're going to have to go back and edit them. They don't write complete sentences. They don't punctuate correctly. So if auto narratives are used, you must go back and fix them to make them readable, to make them where they don't make you look dumb. But my personal opinion is stay away from auto narratives and take the time to develop a good narrative. And once you have the pattern down, it doesn't take very long to set and type out an actual narrative. One of the things I will caution everybody against is don't lean heavily on acronyms. You have to be careful because not all acronyms are the same. What something means here may not be what it means somewhere else. It might not even be a legitimate acronym. It just might be something that a regional or a service or even an individual may use that is not understood across the board. So it's always best to write out your words, to type them out. We have spell check, you have Google, you have all these different resources to actually create a good narrative that looks good, that reads well, that flows, and provides all the information that you need. So looking at a few of these pictures, can you paint a picture in words of this event? You have to consider everything that's going on in this event. It is a little blurry, a little hard to see, but you do see that people have on gloves and PPE. There's obviously trauma, it looks like, to the face. We have somebody that's using, it looks like a BVM. There's not a tube placed. I see a chest strap. So they're probably on a backboard of some kind, or, and is it for immobilization or is it for moving the patient? I don't know a mechanism of injury here, but we obviously have two different types of providers. So it looks to be a serious patient. So there's lots of things that you have to document here. And in this, airway is going to be huge. So we have to document everything about that airway. How was it, what we did to manage it, how it was managed, were we successful, were we not successful, not to mention everything else that may or may not be going on with this patient in the extremities, in the abdomen, the pelvis, or whatever. So this narrative should probably be a rather extensive narrative. It should not be one that you sit down and type in 2 to 3 minutes that's, 3 or 4 sentences, a paragraph. It's just not going to be sufficient. So we need to, again, paint a Bob Ross painting of this and not a kindergarten painting. Here's another one. This would definitely be a story that we told. We came up on this accident, we were dispatched to a rear end, and a car was on top of another car. The likelihood of injuries here is fairly slim, more than likely, but not to say that it's not. But let's just say that you have entrapment of a patient that has significant injuries. Maybe this is an accident that is a result of a medical issue, and now we have to get somebody out of the SUV. That might require a lot more than we typically would use with extricating someone from a vehicle. So we need to paint the picture about the difficulty for access, the difficulty for extrication. The same for the smaller car that's under the SUV. Obviously, this vehicle is hanging over that passenger side. We may or may not be able to open that door. It looks like the rear wheel of the SUV is impeding the door on the passenger side. So access to that patient may be difficult. We may have oil or gas or something leaking from the bottom side of that, not to mention if it's been running, the heat from the exhaust system or whatever. Do we need to document all of that in our narrative? Maybe not everything in our medical narrative, but you certainly need to document the difficulty in patient access. You need to document the things that hindered care, that made it difficult. On the fire side, otherwise, you do need to document the difficulties of access as well, and the things that you had to do to mitigate that, your safety concerns, PPE that you had to wear, bunker gear and helmet, if nothing else, to protect you from the heat from the underside of that vehicle, depending on the route of the exhaust or whatever. So again, we've got to paint a good picture whenever we write our narratives. So we'll go over a few tips here. The reasons that we need to do our best, we need to do our good narratives, is because your freedom and your livelihood depend on it. It only takes one call for something to go wrong, or even not to go wrong, but the perception of that it did, and a lawyer get a hold of your stuff and disprove you. So your freedom, your livelihood is at stake. It only takes a few minutes to do it right. You have that bad trauma we mentioned, you have a cardiac arrest, you have a whatever it is, it might take you a little longer than it typically does to write a narrative, but those extra 5 minutes is worth the investment to do it right, to document everything that you need to document, so that, again, you can keep your freedom and you can keep your livelihood. People in this state, people that I know, have lost their license because of stupid mistakes, because of poor documentation, and that does not have to be you. Use full sentences, avoid abbreviations. I've already talked about that, especially non-standard ones. You know, it's COA times 3. What does that mean? It means something different to everybody, because what are the 3 things that you ask? You know, what are the 3 things that they may be, you know, oriented and alert to? It's just much easier to type out conscious, alert, oriented to person, place, time, event, or whatever it is that you want to actually say. Write like every PCR will be reviewed by a criminal lawyer is one of my best tips that I can give you. If you write like every PCR is going to be reviewed and not just looked at, but critiqued by somebody who is out to get you, then you're going to do your best documentation. Make sure that you paint a masterpiece, a Bob Ross masterpiece in each report. So whomever reads it can sit back and get an actual picture in their mind of the scene, you know, and not a blurry picture, not a puzzle that's got half the pieces missing, but an actual picture of what went on, what you found, what went on, how the call was en route, and should be able to follow that. If you think of a good novel or any good book that you've read, and you can place yourself into that character position, that's what your narrative should do. So EMS is changing. Documentation is becoming more and more important, and that is no surprise. It's being looked at more and more than ever before for all kinds of reasons. So we need to make sure that we step it up and we do what we have to do to get good documentation. We're going to review a few documents here, types of documentation that I have been able to acquire. There are no patient identifiers in here, but it's just a couple of examples of what's out there. Some are better than others. A lot of them, you know, they're missing information. And as someone that does review PCRs, you know, kind of put yourself in that in those type shoes and see what questions these PCRs may spur and may make you want to ask. You know, it gives you just a little bit of information, but you're looking for something more. Also, before I forget, I do want to encourage people, if you are a person that has problems writing, you know, for whatever reason, there are ways that you can get help to better yourself in the areas of writing. So make sure that you come forward, that you seek out that help if you need it. The training department will be glad to help to point you in those directions. Some of the things we can help, some things that we may have to refer out, but there's things like creative writing classes and all kinds of stuff that are available, not just to us, but to really anybody. So let's go through these and then we'll be to the end. So this first one, oh, there's one more picture I forgot about. If we paint this picture, you know, this could be somebody that you go to in their home. Could be somebody at a assisted living place or a nursing home or a hospice. You know, when we paint this picture, you know, is this patient critically ill? Is there something really wrong with her? This may not even be an actual call. It's just a picture of somebody's grandmother that they wanted. So she obviously has some pre-existing things that we need to document if she were a patient, but, you know, is she actually sick? We don't know that. It would be based on your documentation. So to paint a picture of someone that is in poor health, but yet not in a crisis, and they just called because they, you know, needed a transport or because they needed, you know, help moving the patient from one place to the other, you know, we just need to make sure we document. And I thought this was a good picture to demonstrate, you know, the importance of documenting things that are existing versus things that may be acute. So here's our first document here. I'll read through it. It says 53-year-old male patient states that he has been having tightness in his chest for approx 40 minutes. And there's a space with a period. Patient describes the pain as substernal pressure that is dull and does radiate in RT right arm with another space and a period. States the pain is constant and does not go away. Patient requests transport to Piedmont Fayette ER. Patient states that he feels better at the moment. Patient only history is hypertension. Patient is in KA. Then the objective is patient is conscious, alert, oriented ×3. I've already talked about that issue. Pupils are pearl. Skin is warm and dry. Patient states no DIB. Patient denies chest pain at this time with no nausea, vomiting. And the treatment is 12 lead EKG shows normal sinus rhythm. BS, I imagine, is going to be blood sugar in this case, 152. Placed 18 gauge INT in right arm. Transported the patient to Piedmont Fayette ER. Patient was placed in room 1, still pain-free. So there is a lot of good information here, but it is very poorly written as far as punctuation, as far as complete sentences, as far as ease of reading, as far as the actual documentation of the past medical history, events leading up to, many things, in my opinion, should be corrected in this. I would definitely send this back and ask for a much better documentation and thorough documentation on this patient. But like I said, it does have good information, but you know, I would really hate for this to be flashed up on a screen in the courtroom and somebody asks me, you know, about whatever it is, you know, and discredit me because of, you know, my poor sentence structure and incomplete sentences and poor punctuations. Here's our next one. It's a little better. Responded to person hemorrhaging from heart cath incision and difficulty breathing. On arrival, patient 47-year-old female lying supine, A+O X4. Patient stated she had a heart cath yesterday and there is swelling around the incision in her groin/thigh area and bruising. Patient denies chest pain, no nausea or vomiting, but blood pressure, pulse, and pulse ox within normal limits. Blood sugar elevated, 312. Patient stated she had not taken her metformin today, period. No difficulty breathing, Pearl, negative JVD. Patient requested transport to Piedmont Fayette ED, space. Vital signs monitored en route. Normal sinus rhythm on cardiac monitor. Patient left in care of ED staff. Again, there's some good information, but overall it is a very poorly written narrative, incomplete sentences, A+O ×4. Again, that is a non-standard abbreviation that this person has made up. And I always hate it when people put, you know, blood pressure, pulse within normal limits. What are the normal limits? What is normal for this patient? You know, what's going on with this patient? I would assume that the vital signs are noted elsewhere in the PCR. But we just need to watch what we put, how we put it, punctuate, use spaces appropriately, and document a thorough exam, document a thorough history. Here is our last one. It is a much more, I guess, extensive narrative. So history, quadriplegic from motorcycle injury sustained 20+ years prior, Meds/allergies unknown. Subjective 46-year-old male, bedridden, quadriplegic, 10109D, which means dead. That's a 10 code for death, which is not appropriate for a narrative. Possibly from prior evening. Patient's family advised they came into home to check on him and discovered current state. Patient supine in bed, pale blue in color and cold to touch. Patient's family advised patient last seen last night after dinner time. No obvious evidence of injury or foul play noted. Patient's mother advised patient recently suffered from upper respiratory infection, but otherwise patient patient in standard condition. I guess objective. Patient pulseless, apneic, and cold to touch. CM, I suppose, is cardiac monitor. Dash asystole confirmed in lead 1 and 2. No obvious blunt or penetrating trauma noted in assessment. Patient's jaw and extremities rigid. Assessment, obvious death, plan, patient assessment, and CM attached for confirmation of condition. This was Medicaid 3. Staff spoke with family regarding steps to be taken and scene left in care of police and family. So this one, again, there's a lot of good information, but very poor sentence structures. 10109D is not appropriate to use because that is a non-standard 10 code, and we shouldn't be using 10 codes anyways. The assessment was described, I guess, okay, but it could have been done better. I don't like the patient standard condition. I don't know what a patient standard condition is. This particular one, it seems fairly straightforward, but anytime that you document an obvious death, I would definitely really put a lot of effort into that, because, you might not see signs of foul play, but you're not a detective either. That is the police's job. And, what if there was some signs of foul play? What if they determined that something did go on? What if this ends up in court? To me, there's a lot of unanswered questions here. There's a lot of things that, just kind of make you wonder a little bit. But overall, I think it's probably better than the previous two, but still room for improvement. So those were just a few examples of documents that I have come across, and I've seen many, many more that are a lot worse than these. I've seen a lot that are a lot better. So this is the conclusion of this documentation presentation. So if anybody has any questions, feel free to send them to member development, and we will get with you, provide answers. If you need help with documentation, send inquiries, send requests for help. We will be sure to get with you. Just remember, documentation is of the utmost importance. There is a quality control team that is being formed. We have new software that will be also looking at documents. So it's going to be important, not only for these reasons, to document well, but as previously stated, we have to document well for research, for legal issues, for medical issues, for your livelihood, and for everything. So take the extra time, take a few minutes, document properly, document thoroughly, and document well.